So as Dalton said, we're going to talk this afternoon. I'm going to talk this afternoon about timing of starting CLL treatment. That hasn't really changed over the last many years, despite tremendous progress in treatments for our patients with CLL. But there are some things to think about and things to pay attention to that have evolved with time and are more important now with our newer targeted therapies. And I'm going to talk about that a bit more. What I'd like to do is spend 15 minutes or so on the content and then save the majority of time for questions and discussion. These are my disclosures. I receive research funding from a variety of different pharmaceutical companies for therapeutic development, but no personal funds for any activities. This slide shows you a peripheral blood smear of a patient with CLL, and it's a very characteristic peripheral smear. And this is what is seen when we do a blood count and we see a high white count and we look at the cells under the microscope. The red cells with a pale center are red blood cells. And then all of the other cells that appear dark with a dark nucleus on this slide are CLL cells. They are relatively uniform in their size and their shape. And then there's a couple of other cells on this slide that are hallmarks of a diagnosis of CLL. You may have read about them. They're called smudge cells, and they're an artifact of the staining and preparation of the smear. There are two here over to the left. They look like somebody smashed the cells, and they're smudge cells, and there are no other diseases that we see smudge cells in, and they're not a normal feature of a blood smear. So when you see smudge cells, that's a hallmark finding for patients with CLL. CLL is characterized by a high white count, and the white count is high because the lymphocyte count is increased, and those are all, mostly all, the CLL cells, and are higher than normal. Well, they're abnormal cells in the sense that they all come from an original clone, but they accumulate in the blood, and so they accumulate as such they account for a rising and elevated white blood cell count. They also can accumulate in the lymph nodes, and that can cause the lymph nodes to be enlarged, as well as the liver and the spleen. And over time, generally speaking, the lymph nodes will increase in size, the liver and spleen will increase in size, and the white count will rise in the absence of treatment. Also, they like to grow in the bone marrow. And when they grow in the bone marrow, because the bone marrow is a fixed space, in growing in the bone marrow, they crowd all the normal cells out of the bone marrow. So that's the reason that the hemoglobin will drop, because the cells that make red blood cells in the bone marrow are not able to grow there in normal numbers. Also, the platelet count will drop over time. And so in addition to the rising white count, enlarged lymph nodes, etc., we also see a declining hemoglobin and sometimes a declining platelet count as a result of progressive bone marrow involvement. So these are some clinical features that are important. It's the most common type of leukemia in adults, about 20,000, more than 20,000 cases per year in the US. And it's generally a diagnosis that's made in the older population. We tend to see younger patients at academic centers like MD Anderson. In the community, the average age is much higher than it is at our academic centers. The average age at diagnosis is 72. Most patients don't need treatment when they're initially diagnosed and will be monitored and observed, so that most patients don't require treatment initially, and the average age at which time patients start treatment is well into the 70s, 75 or higher. The survival, if you read about the disease and you read about survival, the textbooks and what you'll read is somewhat behind on the outcomes, particularly with all of the very rapid evolution in our treatments. So you read about survival times, and the survival times that you'll read about probably are not accurate because they're based on old treatments, chemoimmunotherapy-based treatments, and the literature hasn't quite caught up to how good of outcomes we're now achieving with our newer treatments. There are other things that can occur in CLL as a result of the CLL that contribute to the morbidity and mortality, and I'll talk a little bit more about those things. And those things are becoming more and more a topic of conversation in the clinic than they ever were. And I spend a lot more time talking about survivorship and health maintenance with my patients than I ever did, and probably more than I talk about treatment these days. There are diagnostic criteria. As I said, the cells tend to accumulate in the blood and the lymph nodes. These cells all arose from one abnormal cell and grew and expanded. And those cells have characteristic features on them that allow pathologists to identify them as CLL and identify a patient as having a diagnosis of CLL. There are protein markers that are present on the cells, and it's the constellation of these proteins that are identified by the CD with a number, CD5, CD19, and CD23. The presence of those protein markers on the cells, they characterize the cells as CLL cells and the disease as CLL. You can make the diagnosis from a blood sample. You don't need to do a bone marrow. And then there are some other features, and I spent a lot of time in my earlier career characterizing these prognostic factors and trying to assess how they were useful in prognosticating for our patients. But with our newer treatments, because they're so effective, these features are less important and we pay less attention to them. There are chromosome abnormalities that we identify by FISH. That's fluorescence in situ hybridization. There's a test called the IGHV mutation status. Those two are probably still relevant, and I'll describe why that is. And some of the other ones that we used to pay a lot of attention to, we don't necessarily pay much attention to at all anymore. Things like beta-2 microglobulin, CD38, and ZAP70. Most of the time, the diagnosis is incidental. Patients will have a routine blood count with their primary care provider, and they notice that the white count is elevated, and it's because the lymphocyte count is elevated, and that prompts a workup, which is typically, again, a flow cytometry test from the blood. Usually, individuals don't have any symptoms at the time of diagnosis. Sometimes they'll present with enlarged lymph nodes, and the diagnosis will be made based on a lymph node biopsy. Occasionally, I'll have a patient with some fatigue, but generally, most patients at initial diagnosis are asymptomatic. They don't have any symptoms. I mentioned about the bone marrow involvement and disease involving the bone marrow that grows without treatment will impair bone marrow function and result in low platelet count and low red blood cell count. The disease, the main reason I got interested in the disease back in the late 90s when I was a fellow was because I had a PhD in immunology, and it's a particularly interesting disease from an immunologic perspective. There are immunologic features of the disease that are unique to CLL, and that are part of the reason we still struggle with the disease and the morbidity and mortality that can be caused by the immune dysfunction. The immune system doesn't work normally, and as a result, patients are at increased risk for infection. They're also at increased risk for other cancers because they don't have what's called immune surveillance. So we have a big research program that's dedicated now to understanding the immune dysfunction and also at working on strategies to correct the immune dysfunction that we see in patients. Because we become very, very effective at controlling the disease and treating the disease, but not so much at restoring the immune function. And surprisingly, even if we get a patient in a good deep remission, MRD undetectable, their immune system doesn't necessarily correct or restore as a result of being in that remission. So it's very important for us to dedicate our attention and efforts on immune restoration. There is a staging system, you may know this, and the staging system is illustrated here. It's referred to as the RISE staging system. Most cancers are staged. The staging system for CLL is a little bit different than solid tumors. Solid tumor staging is based on how advanced and widespread the disease is. CLL is different because those cells circulate around the body naturally. That's what they typically do. So you'll find them everywhere. And so the staging isn't as much based on where you find them, where you find the CLL cells, but other things that they can cause. High white count, enlargement of the liver and the spleen, enlargement of lymph nodes, and then, as I mentioned, compromise of the normal bone marrow function, a reduction in hemoglobin and platelet count. So the most advanced stage is where patients have a low hemoglobin and a low platelet count. Now, the median survivals there on the right are old data, so those are not relevant any longer. And this is an old paper that Dr. Rai published many years ago, and it illustrates the staging system. But what I probably should do from now on is remove the survival information because that's old data. Okay, so a little bit about the FISH and the prognostic features. These are features that have been correlated with outcomes. They're not necessary to test for at initial diagnosis, but we like to know them when a patient needs to start treatment because they do help direct treatment. So FISH is fluorescence in situ hybridization. It's a test that allows us to identify specific chromosome abnormalities. The two that we pay most attention to right now are 17p deletion, which is basically the number one, and then 11q deletion. 17p deletion has been a high-risk feature. It still is a high-risk feature, but our patients are doing much better with our targeted therapies than they did with chemoimmunotherapy. So while we pay close attention to 17p deletion, the prognosis is not nearly as dismal as it used to be when patients had that feature, including when they need treatment. That next big bullet is the IGHV mutation status. Patients are characterized as having a mutated or an unmutated immunoglobulin gene. An unmutated immunoglobulin gene is generally associated with disease that has a propensity to grow. And so for an unmutated immunoglobulin gene, the time to needing initial treatment is usually shorter and the remissions are usually shorter if you're talking about fixed duration treatment like chemoimmunotherapy or venetoclax-based therapy. With targeted therapies like a BTK inhibitor and our combinations, the prognostic strength of IGHV mutation is much less than it used to be. Patients are doing very well whether or not they have a mutated or unmutated immunoglobulin gene. Complex karyotype is a feature that's gotten more attention recently. That refers to the number of chromosome abnormalities per cell. And so if there are 5 or more chromosome abnormalities per leukemia cell, that puts a patient in a high-risk feature. Or a high-risk category. And as I mentioned, ZAP70 is not used so much anymore, nor is CD38. The main ones to pay attention to are those first 3, FISH, IGHV mutation status, and complex karyotype. I'll talk a little bit more in a minute about those again. There are a number of genes that have been identified to be mutated in CLL. And despite a number of years of work that have been done on these mutations, there's very few that are very helpful in directing therapy. And I might add, again, these features and the gene mutations are not necessary to be tested for at initial diagnosis. They can be useful in directing therapy, so we recommend them to be done before patients need treatment. Some of them change, like the FISH can change and the complex karyotype can change. So those should be tested if you have a patient who's been treated in remission and their disease comes back and they need to be retreated, because those can change. The immunoglobulin mutation status doesn't necessarily change. And we don't initiate early treatment for patients regardless of what features they have. So if they have a 17p deletion, that's not an indication for early treatment. Nor is a mutation in any of these other genes like Notch1 or some of the other ones that you may have heard about. Okay, so this is the guidance for when to start treatment. It hasn't changed in many, many years. And the reason why it hasn't changed is because there's been many trials that have been done, randomized trials, to look at whether or not early treatment results in longer survival for patients, and it doesn't. And so early treatment does not guarantee or assure that a patient will live any longer than if you wait until they have one of these indications to start treatment. So we're still in a situation where we're starting treatment only when patients have an indication for treatment. I think most of us doing research in CLL believe that, well, probably there are patients that will benefit from early treatment. We need to do the trials to demonstrate that. Perhaps it's a patient with 17p deletion or 11q or some other higher risk feature. But we don't have the data yet that supports that. It was not true in the times of chemoimmunotherapy. We're more confident that it's probably the case with the targeted therapy, but we don't have the clinical trial data yet to demonstrate that. And so the criteria for starting treatment hasn't changed. And those, I'll walk through those quickly now. So patients' indications for treatment are symptoms. So these are symptoms that are referable to the CLL that we want to go away with effective treatment. And they need to be symptoms that are having significant impact on the quality of life. Those are usually fatigue, night sweats, unintentional weight loss. And again, those we are most comfortable if we're assured that those will go away with effective treatment. Progressive bone marrow failure refers to a low hemoglobin or a low platelet count. I usually use 11 for the hemoglobin. So a hemoglobin that's dropping and goes below 11 is an indication for treatment. And for a platelet count, that's 100,000. So a platelet count that's dropping and goes below 100,000 is an indication for treatment. Autoimmune problems can be associated with CLL, and those have been an indication for treatment. Significantly enlarged spleen and significantly enlarged lymph nodes are shown there. We don't use as much the lymphocyte doubling time anymore. That in isolation, that is very, very, very uncommon. Usually we see a rapidly rising white blood cell count or lymphocyte count associated with some of these other features like symptoms, etc. So just to recap, disease-related symptoms, if they're significant and impacting on quality of life, anemia that's progressive and a hemoglobin, excuse me, of less than 11, low platelet count that's progressive, and a platelet count of less than 100, massively enlarged lymph nodes or liver or spleen are indications for treatment. And we don't treat early, even for patients who have high-risk features, unless they have one of these indications. The other comment that I would make is these are the indications for initial therapy. There are also indications for retreatment. So, for example, if we have a patient who goes on a venetoclax-based treatment, venetoclax plus obinutuzumab, they get a year of treatment, they go into remission, they're observed for 5-6 years. Their disease starts coming back. We don't restart treatment for that patient unless they have one of these indications for treatment. And patients can be observed for a long time with measurable disease in that setting and not have indications for treatment. Treatment, and I wasn't intending to talk very much about treatment today, has evolved considerably, and we're in an era of targeted therapy with our oral agents, a BCL2 inhibitor, BTK inhibitor, and our outcomes are extremely good with those therapies. And this table, and as I said, I'll make these slides available, summarizes the drugs that are currently available for management of CLL. And I think I've covered most of the salient and important features of patients who are newly diagnosed and monitored, and the indications for treatment. Again, we don't start early treatment even if patients have high-risk features. And the ones that I've put on this slide are the ones I've highlighted as features that need to be evaluated that do correlate with outcomes, particularly the TP53 status, 17p deletion, and mutated TP53. And are important features to monitor. Okay, this is my last slide, and I think for purposes of this discussion, it's probably the most important one. These are the health maintenance strategies that are very important and that I spend a lot of time talking to patients about in the clinic. Screening for other cancers is essential and is important because patients have a higher risk for developing other cancers. Skin cancer is the most common. They need to see the dermatologist once a year. For women, breast cancer, it's important for diligent screening for breast cancer. For men, prostate cancer with an annual PSA. And then screening for colon cancer. Now, these, other than the annual skin cancer screening, the breast, the prostate, and the colon cancer screening are the standard screening schedule and testing that everybody should be doing, but it's critically important for our patients with CLL to adhere to the schedule and to make sure that they're regular about doing all of those, because early detection is critical to treatment and curing and eliminating these other cancers. And then infection prevention is highlighted at the bottom of this slide. The annual flu shot, shingles vaccine is indicated for our patients with CLL. Pneumococcal pneumonia vaccine with boosters every 5 years. We do talk about the RSV vaccine, and then the annual COVID-19 boosters are important. So these are important things for our patients to think about, to adhere to, and hopefully I will be able at some time in the near future to come back to you and talk to you about the strategies that we've developed for restoring the immune system and immune function. So with that, I'll finish, and thank you for your attention.
That was wonderful, Dr. Wierda. Now is our time for Q&A, and I know that we've got quite a few coming in, and I'm sure we'll get many more coming in throughout. Keep in mind, I will generalize your questions to make it more applicable to everyone in the audience. So please don't ask super personal medical questions. This is really just more of an information session. The first question that I wanted to address is coming from an individual in the audience, and they're asking, so I think he answered the first part pretty well, but is treatment necessary for CLL, or can it be treated through herbs, vitamins, and dietary programs?
So there haven't been any studies that have clearly demonstrated remissions or any impact on survival with herbs or other holistic approaches. Now, I think those types of things can be important. I think a good diet is important. Stress reduction is important. Exercise is important. But those what I would refer to as holistic strategies or non-traditional, non-Western medicine traditional approaches have not been proven effective strategies for management of CLL, particularly for patients who have indications for treatment. We have exceptional treatments if patients need treatment. There have been some studies with things like EGCG or green tea extract that have shown some shifts in white blood cell count in patients who've been on those drugs, but none of them have, including EGCG, have been demonstrated to be effective management drugs.
Okay. Next up, this individual is asking, what percentage of CLL patients have enlarged lymph nodes in the watch and wait period? Is having enlarged lymph nodes a sign that they might need earlier treatment or treatment in general, or is enlarged lymph nodes not really cause to treat alone?
Simply enlarged lymph nodes is not an indication for treatment. Most patients, I would say the majority of patients who have had their disease for a while will have nodes that you can feel, that I can feel in the clinic. Sometimes the patient can't feel them because they're enlarged. The patients may not know what to look for or where to look for the enlarged lymph nodes. But enlarged lymph nodes in and of themselves are not an indication for treatment unless they're causing a clinical problem. If they're pressing on something, which is very uncommon, that's not generally an indication for treatment. They don't cause anything bad. Simply having enlarged lymph nodes is not a problem, and many patients are monitored and observed with enlarged lymph nodes and don't need treatment. And in general, like the white count will tend to go up over time, the lymph nodes will tend to get larger over time.
Okay. And then next up, we have an individual asking if you could expand on the when it says plus, minus, as well as dim on some of the testing. So I believe this is likely the flow testing, just kind of what the positive means, negative, or what that dim might mean.
Right. So the positive means that the protein or the marker, CD5, CD19, CD23, are positive or present on the cells of interest. They are present on the characteristic lymphocyte that is the hallmark of CLL. So positive means that they're there, the markers are there. Negative means that the protein is not there. So other markers might be what should not be there. So other markers like T cell markers, CD4 shouldn't be there, so the cells would be CD4 negative, etc. So the positive means the protein is there on the cell. Negative means it's not there on the cell. Dim means it's there, but in low levels. So CLL, there's a particular protein that's found on B cells. CLL cells are B cells. That protein is referred to as CD20. And that protein is the target for a couple of the drugs that we use to treat CLL, rituximab and obinutuzumab. And you may have heard of those antibodies that bind to CD20. CD20 is present on normal B cells. It's present on B cells of other B cell malignancies, like diffuse large B cell lymphoma. It's also present in CLL, but it's at a lower level, generally speaking, than all of those other examples where you find CD20. And that's what DIM refers to. It's a lower level of protein on the surface of the leukemic cells.
Okay. Next up is what specific lab testing is the best way to assess my return of immune function? This individual is asking in the context of obinutuzumab venetoclax therapy, but just is there a way to really test if immune system function is returning?
Unfortunately, there aren't great tests to survey immune function and to say, yes, your immune system is restored to normal. A couple of the tests that we use are correlated with risk for infection. So for example, quantitative immunoglobulins measuring specifically the IgG level can correlate with risk for infection. IgG is a type of antibody that's found in the blood. It's usually low in patients with CLL even before they've had treatment. In patients who've had obinutuzumab, because obinutuzumab targets the CLL cells and normal B cells, obinutuzumab can exacerbate the low IgG level. And so one of the things that can be measured that reflects sort of risk for infection is the IgG level. There is a drug that we can use to restore that, at least temporarily, which is called IVIG. So IVIG is a preparation of IgG that has been collected from donors and is administered IV to patients. It will circulate in the blood. It doesn't fix the fact that your B cells aren't making adequate levels of IgG. It only restores those levels temporarily for 2 to 4 weeks. And so we do give IVIG for IgG replacement in patients, particularly those who have an IgG lower than 500 and have had infections. There really aren't other tests. We have historically tested CD4 and CD8 T cell numbers. Those can also correlate with risk for infection, and are particularly low with certain types of treatments that we give, like chemotherapy, fludarabine, for example. But venetoclax, obinutuzumab, is not necessarily thought of as a treatment that will deplete T cells, and so it's less CD4 and CD8 T cell counts is less relevant for patients who've had obinutuzumab and venetoclax.
Okay. This next one is a interesting one that I think is a little personal, but I think it's a good one to cover. And it's asking about the difference between CLL or mantle cell lymphoma. They said that they're not it. They've seen a couple different specialists who can't determine for sure whether they're CLL or mantle cell. And when it comes time to treatment, how will their doctor know what to treat them with at that point?
Yes. So that's a good question. CLL and mantle cell are B cell diseases. They're sort of cousin diseases. The cells under the microscope look pretty much the same. The difference between a patient who has CLL versus a patient who has mantle cell, I mentioned those markers or proteins on the surface of the cells that we measure or use to identify and characterize the disease. CLL cells have on their surface CD5, CD19, and CD23. Mantle cell cells express CD5 and 19, but typically don't express CD23. That's one way we can potentially distinguish those two diagnoses. Another way that we can potentially distinguish is what the person who asked this question, Lynn, who asked this question, is the cyclin D1 expression. So in mantle cell, cyclin D1 is high. In CLL, it's not high. And so and then there's a chromosome abnormality that's associated with that high cyclin D1 expression. It's a particular translocation between chromosomes. So there are several things that can be evaluated to distinguish whether or not an individual has classic mantle cell or classic CLL. Now, you know that in medicine, nothing is ever absolute. If there's a test question, you never pick the answer that says always or never, because that's medicine and biology just doesn't work that way. So there are patients who can have features that are overlap and will have what can be referred to as an atypical CLL or an atypical mantle cell. And so it may be that this individual fits into that type of category where they don't have the classic features for a diagnosis of CLL. I think the most important feature for this individual is that their cyclin D1 is negative. I would tend to put that diagnosis closer to CLL than mantle cell. And we do see similar outcomes or similar responses with our treatments between mantle cell and CLL, although mantle cell is thought of as a more aggressive disease that tends to be more resistant to our treatments. So hopefully that provided some insight into that question.
Yeah, I think that was a very good answer for that one. This next one, I'm going to make it a little bit more generalizable, but so they're asking about currently being treated with Calquence, which is a calibrutinib. Obviously, there's no way to know for sure how long something will work, but what are some indications that treatment may no longer be working? And then indications to treat with something else if they are on ibrutinib, acalabrutinib, one of these BTK inhibitors.
Sure. So the BTK inhibitors that you're referring to are the initial BTK inhibitors that were developed. Those are referred to as covalent BTK inhibitors. They bind to the protein BTK and they inactivate the protein, the enzymatic activity of the BTK protein. They irreversibly inactivate it. So the only way the cells can recover from that is if they make new BTK that doesn't have the inhibitor bound to it. There are mutations that can occur in BTK that render those drugs unable to bind to BTK and block its function. And we see those mutations in patients who are developing resistance. So one of the things that I typically will do in a patient who's been on a covalent BTK inhibitor, ibrutinib, acalabrutinib, or zanubrutinib for a while, and their white count starts to go up or trends up, or their lymph nodes begin to enlarge, I'll test for BTK mutation. And they're relatively common among patients who are developing clinical resistance. And so that's one test that can be done to confirm resistance. But ultimately, the feature that will prompt doing something different is if the white count is going up, despite a patient being on a dose of the drug that would be effective. Or at least the highest tolerable dose of that drug. So if the white count's going up, if the lymph nodes are enlarging despite being on an active dose of the drug, that's when we suspect the patient's developing resistance. I test for mutations, but I start thinking about other treatment options for those patients, whether it be a non-covalent BTK inhibitor like pirtobrutinib or a venetoclax-based treatment. Or a combination of venetoclax-based treatment.
Okay. Next up, and if we don't get through all questions, I do apologize. We've got a pretty lengthy list, so we're going to do our best to get through as many as possible. But if we don't get to your question, we do apologize. So our next question is coming from an individual saying that they've read that approximately 30% of CLL patients never require treatment. Are those individuals typically or always IGHV mutated?
Not necessarily. There are patients who have unmutated V gene that have many years of treatment-free observation. Generally speaking, patients who have an unmutated V gene will ultimately need treatment. And it's usually, generally speaking, shorter than the time for patients who have a mutated immunoglobulin gene. But most of our clinical trials, for example, that enroll previously untreated patients, those trials enroll 60% patients 60% of the patients who enroll on those trials have an unmutated immunoglobulin gene. The remainder, 40% or so, have a mutated immunoglobulin gene. So most patients with an unmutated V gene ultimately will need treatment, but not all of them. Patients with a mutated V gene tend to have a more prolonged period of observation, and many of them don't need treatment at all, ever.
Okay. Next up is, do you have any thoughts on Pemgarda for CLL patients?
We have had difficulty having access to Pemgarda. So this is the antibody that has been used for prophylaxis, and it's difficult to get. I don't think I've had any patients who've been able to access it. Today, unlike 4 years ago, 5 years ago, most individuals have had exposure to COVID-19. Most of them have cleared an infection and have some immunity to COVID-19. So I think I think the risk for our patients is much lower than it was initially. And I do recommend boosters, although I have some concern about the long-term effects of repeated exposures to the booster vaccinations. I wouldn't recommend PEMGARDA as an alternative to vaccination. And like I said, I have not had patients that have been able to access it recently.
Okay. And then this next one I'm going to ask, can I go out of order here because it ties
Sure.
in very well? But is there a concern about receiving the flu and COVID vaccines simultaneously?
Sure, I would not do them simultaneously. I would separate them by at least 2 weeks because you can confuse the immune system and overstimulate the immune system, and it's probably better to stagger them.
Okay. And then kind of sticking with that theme, do you have any recommendations for patients in terms of infection prevention, such as masking, hand washing, especially during this kind of high cold flu COVID season, or traveling on airplanes, just kind of general infection management risk?
Sure. Well, good hand washing, I think, is good for everybody, not just our patients with CLL. I still use hand sanitizer. Masking is probably more optional. I think the air handling and the risk for having, unless somebody's sneezing on you, which you don't want, but it's traveling in an airplane is because of the air filtering and air handling is probably a lower risk. I don't generally recommend that everybody wear a mask while they're traveling, but certainly they should be washing their hands and avoiding anybody who looks or sounds sick.
Okay. Kind of getting away from the COVID theme now, but this individual's asking about TP53 mutations. What does it mean when you say TP53 can change? They say they have a TP53 mutation currently, but they want to know what that change might mean.
Yeah. So TP53 is the gene that is located on chromosome 17. 17p deletion means that the cells have lost at least one copy of that TP53 gene. Most patients who have a 17p deletion also have a gene, the TP53 gene, mutated. What I meant when I said that can change, I meant that patients who don't have that feature early on in their disease, either 17p deletion or mutated TP53, can acquire it over time. So they may get treated, they may be in remission. When their disease comes back, they may not have had 17p deletion or mutated TP53 initially, but they could have acquired it as their disease has been treated and is recurring. We don't generally see it go away. So it would be unusual for us to have a patient who started out with 17p deletion or mutated TP53. It would be unusual to see that patient lose that feature of their disease. It doesn't go away. It doesn't go away necessarily with treatment, but you can acquire that feature through treatment.
Okay. Next up is what is the measurement of the spleen that causes concern?
What is the measurement of the spleen that can cause concern? I don't
Yes.
know that I would necessarily give it a number. I would say an enlarged spleen that is concerning that we start having discussions about is if patients feel abdominal distension, if they are having difficulty eating a meal, if they get full sooner because their spleen is pushing on their stomach and they can't eat a reasonably sized meal. They have to eat small, frequent meals in order to get their nutrition because their stomach feels like it's full sooner than it would be otherwise because the spleen is pushing on it. So I don't know that I would give it a number. It's more the symptoms and problems that can come about because of an enlarged spleen, discomfort and difficulty with eating and maintaining weight.
And that seems to be kind of a common theme amongst a lot of these symptoms is really until it's causing issues with an individual's life, it's often not a hard and fast number.
Right. And the thing that I would add to that is in CLL, things don't happen quickly. So these are things that happen gradually, usually over months, sometimes years. And so it's unusual for somebody to wake up one day and have something that's prompting treatment that's not anticipated or hasn't been progressing over several weeks to months.
Okay. This next one I think is a really good clarifying question, but does the information discussed today also include or cover SLL?
Yes, it does. And so SLL is small lymphocytic lymphoma. This is a much less common diagnosis than CLL. It's essentially the same as CLL, except patients have enlarged lymph nodes, liver, spleen can be enlarged, bone marrow is usually involved, but they don't have an elevated white blood cell count. They don't have an elevated lymphocyte count in their blood. Those cells, they're abnormal cells, like to reside and stay in the lymph nodes and the other tissue. They don't like circulating around in the blood like they do for CLL.
And I'm gonna selectively choose just a few more questions because we are getting a little low on time here. So again, if we don't get to your question, I do apologize. Um, but this person is asking, is there an average amount of time that you see um, someone who has CLL before they typically need treatment?
Oh, it's usually years. It's usually, I think if we look at our data at Anderson, the average time between initial visit at Anderson and when a patient may need treatment is probably on the order of 3 to 5 years. So it's several years before they need treatment that they're observed. That's not a bad thing. I think in the older days, patients used to be very uncomfortable with watch and wait. I'm comfortable with it because we have exceptionally good treatments that we can apply today. And there's a lot of research that's going on, and the options will be better next year and the following year and the following year. So it's good to be patient with this diagnosis and with when to start treatment, because our treatments are remarkably improving in a very short period of time. That wasn't the case when we were using chemotherapy. It's the case now with our targeted therapies.
And then a follow-up to that is, how has the side effect profile improved with these newer targeted treatments?
So the side effect profile has improved with the BTK inhibitors, particularly because now we have the second generation BTK inhibitors. The second generation covalent BTK inhibitors have a narrower target that they bind. So they'll bind more selectively to BTK than ibrutinib, for example. So the second generations are the acalabrutinib and zanubrutinib. They have less binding to non-BTK targets like ibrutinib does. So ibrutinib will bind to other proteins, and that results in an increase in the side effect and toxicity profile with ibrutinib compared to acalabrutinib and zanubrutinib. Pirtobrutinib is even more selective. And so the drugs have become more selective for their target, and in doing that, they have less what we refer to as off-target binding and activity, which is associated with a lower risk for side effects and toxicities.
Okay. And then this last question, I'm going to kind of make an amalgamation of several questions that I've gotten in. But in this current age of targeted therapies, how is it decided what therapy an individual should be treated with, be it a BTK inhibitor, one of the many options, or a BCL2 inhibitor if they're older, younger? How, as a CLL specialist, do you look at an individual and say, this is the right treatment for you?
Yeah. In 2 minutes, there's not enough time to talk about that. I could spend a whole hour talking about this. This is something that's very important that we spend a lot of time thinking about and talking about. I'll just give you some generalizations that help direct us in terms of our first line therapy, at least. Patients who have a 17p deletion, today, many of us think that they should be on a maintenance type treatment as opposed to a fixed duration treatment. Maintenance would be a covalent BTK inhibitor, either acalabrutinib or zanubrutinib. So 17p deletion, it's a bit different than the others. The other features, and BTK inhibitor-based therapy, I think, is the preferred strategy until we have data that shows that fixed duration outcomes are just as good as with a BTK inhibitor. There's more toxicities in older patients, and so whatever drug we're using, we tend to see more side effect and toxicities. For the BTK inhibitors, for venetoclax, for the CD20 antibody in individuals who are older. So we have to be cautious about that feature and sort of being not over treating those individuals who are older and likely to have more side effects and toxicities. My preference for strategy for treatment is time-limited fixed duration treatment. I like the concept of giving a patient a year or two of treatment, getting them in remission, and having them off treatment for many years. And so there are a number of ways that we can achieve that. We did a lot of work with ibrutinib plus venetoclax. The problem with that combination is ibrutinib has side effects and toxicities associated with it. Excuse me. There are other regimens that are probably better tolerated and more effective. I think what we'll see in the next few years is a lot of discussion about a lot of different regimens that are fixed duration regimens, and discussion about which is the right regimen for which patient. And we don't have that figured out. I think it's going to take some time to figure it out, and we'll work on that. Again, there's a lot for us to do in CLL. Fortunately, the outcomes are exceptionally good, and we'll figure those things out. Our survival for our patients with CLL is paralleling that with their aged matched non-CLL individuals in our population. So a diagnosis of CLL, even if you need treatment, doesn't mean that your lifespan will be shortened by your diagnosis of CLL. It may require treatment, but we're doing exceptionally well with our therapies in patients with CLL.
You did a great job covering, well, truly everything, but to cover that really big concept question at the end there in about 2 minutes, that was very impressive. So just thank you for this presentation, taking so much time to answer all of these wonderful questions. Truly, we are so honored and lucky to have you. So just thank you for everything that you do for this community.
Thank you. Thank you to HealthTree Foundation, and thank you for everybody participating in this. And as I said, my slides you're welcome to have a copy of my slides.
Wonderful. Thank you so much. All right. And we're going to wrap up here momentarily. I did want to let everyone know that we have a end of the year fundraising program going on right now, and we were fortunate enough to receive a 3-to-1 match. So thanks to a $1.5 million matching challenge from Paula and Roger Riney Foundation, your gift will go 3 times as far. So if we reach 500,000, we'll be bringing in a total of 2 million to help power blood cancer research. So if you're in a position to donate this season, we would love if you would consider the HealthTree Foundation. If you can't donate, being part of our research surveys, connecting your medical records, really helping power research forward is always greatly appreciated as well. And then as we're getting ready to hop off, I do want to remind everyone about that short survey for you to complete. It really does help us. We can really help tailor our educational programming to what you're looking for. We do have a few more upcoming educational events. On November 14th, we have Empower Your Mind, Journaling to Build Resilience for Patients and Caregivers. And then on November 20th, we have our latest in our Community Gather event series. These events are geared more towards getting the community together, speaking with one another, so they don't have a formal speaker. It is really more of a group discussion. And that one is going to be titled Community Gather Event, Thankful Hearts, Stronger Connections. We will have another community gather in December as well. I just haven't set a date for that one yet, but it will be coming. So we will have at least a few more events for this community by the end of the year. So be on the lookout for that. I will go ahead and keep the call open if anyone would like to speak with me or with one another. But if you need to hop off, I understand. And want to give another thank you to AbbVie for being our sponsor for CLL Central. Truly, without their support, we wouldn't be able to host events like this. So, big shout out to AbbVie. It is greatly appreciated. And before we hop off, just thank you to everyone for coming today. It is so appreciated to have your support in really building this community. Um, Obviously, big thank you to Dr. Wierda. Having the opportunity to hear from specialists like himself is such an honor. So we are truly so fortunate in that way. I do have my email on this slide here. Feel free to reach out to me at any time. I'm happy to help answer any questions. I love research, so if you've got some questions and you want to look into some things, let me know. I'm more than happy to work with you on it. But I appreciate each and every one of you for sharing part of your day with us. And I'll go ahead and shut the recording off and stop the screen share if you would like to stay on and chat for a little bit. If not, I hope you have a wonderful rest of your day.